Colonel Cola does not waste time trying to explain things to herself out loud. Alright, so we're second to last topic for block one. This is another obstructive disease, so like I promised, we're going through the anatomy of the lungs as we talk through disease processes. So we're still in that upper airway. We're still in the conduction area. We're still in the bronchi, the bronchioles. We'll get down a little bit into the next phase of the lungs, which is the parenchyma, the actual lung. But right now we're still in the airway. So we're still talking about things like wheezing, rhonchi, dyspnea, short of breath, tightness in the chest, kind of the upper airway types of complaints. So this one is a little bit different than asthma. There is sometimes some overlap with this. Damn, this is like really city. There is sometimes some overlap with these, but as a pure disease process, this is going to be more correlated to older smokers. We'll talk about a few cases where people develop this early because of genetic reasons, but in general, we're going to be talking about old smokers, people that have smoked a long time, and now they have developed this chronic airway condition. So obviously this is a big pants topic. As we've seen smoking go down, we have seen a little bit of a decrease in this diagnosis. However, next block we'll talk about something called toxic lung injury, which is more aligned with the vaping. So unfortunately that has gone up a little bit. But for COPD, we'll talk about, just like we did with asthma, we'll go over the pathology, how it presents, how we stage it and do all those little doctor words, how we describe it to each other as colleagues and in notes, how we manage it, how we treat exacerbations, and then at the end, we'll talk about this alpha-1 antitrypsin, which is the genetic condition where people will develop COPD-like symptoms, but it'll be much earlier than we typically expect. So one of those zebras, very not common, but one of those, if you don't know that it exists, you won't think of it in your differential. So overview. So something that you need to keep in mind, the term chronic obstructive pulmonary disease has two different disease processes that we're including in this. One of them is chronic bronchitis, which is where the repeated insult of that smoke going in that airway causes increased production of bronchial mucus and inflammation. And so the definition we use is excessive secretion of bronchial mucus, resulting in a daily productive cough for 3+ months, occurring over 2+ years. I will not make you memorize that. I've never seen them on a PANTS test. That is just how we define it. But it is someone who has daily productive cough. It's not, remember, it's not an acute cough. They haven't been complaining about it for a few weeks, and then it's gone. It's something that recurs. It lasts a long time when it happens, so it's not like a virus. It's not like when they have the symptoms, they have it for 1 to 2 weeks, they have a little fatigue with it, they get a little chills, fever. So it doesn't present like that. It's fairly singular to this increased mucus production. And they're coughing a lot, and it's going on for a long period of time. And it's not just something that happened once, right? We've been seeing it happen in a recurring pattern. These are the patients, these are the kind of things that you need to elicit in order to say, I think this might be COPD, we need to go evaluate for it. So. It doesn't mean that if a 65-year-old person who smoked forever, right, and you say, how long has this been going on? And they say, oh, a little over a year. It doesn't mean that you're going to say, well, it can't be COPD, right? Of course you're going to think that. In medicine, we make these definitions. I will not expect you to memorize that. I just want you to understand that this isn't acute. This is something that we'll see recur over time. Emphysema is the other one that we talk about. That is when those same insults, which is usually tobacco, causes permanent enlargement of the alveoli. Clinically, we can see these as two distinct conditions, but in most cases there's overlap. In most cases, people have a little bit of both. I will teach you what this looks like as a predominant result of smoking, and I'll let you know what this looks like as a predominant result of smoking. Treated a little bit differently. PFTs will look a little differently, right? Because this one we're looking at FEV1, FVC changes, and this one we're talking about actual loss of tissue, so this one will have more of those restrictive changes. The FVC will be down. So again, when we say COPD, there's two types. And of course, this is the big one. Very, very rarely do you have a patient that has COPD that's never touched a cigarette in their life. Otherwise, this alpha-1 antitrypsin we'll touch on, but a lot of other times it's because they're being exposed to things that cause the same injury, either from a secondhand situation or from something in the environment. All right, so smoking. So what happens when you smoke besides totally relax and enjoy your time? And then sleep. So what happens when you smoke? So you're inhaling this tobacco, you're inhaling the heat, you're inhaling the chemicals in there. So you're introducing something to the body that the body sees as caustic, right? So it's going to mount some immune response to it. And that is usually, right, this increased mucus production. Your cilia become paralyzed, so you're not moving that mucus up, and you develop some fibrosis of that airway over time. So you'll get luminal diameter will decrease, and then physics tells us that that airflow won't be as efficient. You know, these things up here, those are just part of your immune system. So if I told you you have increased mucus production, but your cilia are paralyzed, so they're not clearing that mucus out, so that mucus is sitting there all yucky and mucky, what do you think one of the biggest problems with COPDers is? Pneumonia. So when we talk about treating COPD exacerbations, we'll talk about giving them antibiotics. Because that mucus just sits in that airway. Yeah, they're coughing it up, but if it sits there long enough, it starts to grow bacteria. It becomes a nidus for bacteria. And then the second one, emphysema, that's where we literally just destroy those alveolar walls. And so those terminal air spaces get enlarged and they trap air. So your volume of air that you can move, which is your vital capacity, goes down. FVC is down. What happens to the residual volume, usually in these cases? Does it go up or down? Down. Residual volume, the air left in the lungs, it's going to go up, right? So that's why if we have a restrictive disease, we send them to get the body plesiography. It has a high residual volume. We can call that emphysema in most cases. So that's where that ties in. All right. This is very important. I've used this in clinic, so it's an FYI. I don't expect you to memorize it. I won't be like, you know, if they stop at 35, I'm not going to ask you any data about this, but I want you to understand the power of this slide when it comes to talking about patients about smoking. So down here, this is where we say someone will be disabled. So long-term smoking, someone starts smoking at 25 and they smoke until they're done, they will start to become disabled between 50 and 75. If they stop smoking when they start to become disabled, so like, oh my gosh, now this is really affecting me. I didn't really notice it before, but now I can feel it. So now I'm starting to have shortness of breath, dyspnea, I've developed COPD, I have to be on meds, it sucks. So then they're finally motivated to quit smoking. That can actually buy them a little bit more time. The big one I like to point out to people is before you even have symptoms, if you somebody quit smoking at 45, then potentially they never reach that point of disability. It's not too late. And so I use this with patients a lot who think, what's the point now? I'm 45 years old. And I really try to tell them, statistically, you can still make a difference in how this long-term smoking affects you in terms of disability. And not being able to breathe sucks. Being short of breath, having to climb a flight of stairs and then stop and catch your breath. That is not a pleasant way to live the end of your life. Trying to, move your oxygen so you can take a hit of your cigarette. Which we all know that happens. All right. So what are these patients going to present with? So we'll talk about two different kinds of patients. We'll talk about our chronic bronchitis patients and our emphysema patients. But in general, it's a combination of being short of breath. They'll come in and say, I'm coughing. They'll report some sputum production. And I hope your brains are already saying, what if they say they're short of breath? I need to include COPD in that. Well, what else should I be including in that, right? So as you see these diseases and you see what these chief complaints can include, that way when you have a chief complaint and you say, all right, build your differential, you start to kind of backwards plan these. Okay, this is going to be one of them that I'm going to need to include when I have a patient presenting with dyspnea. All right, so this is the hallmark, similar to asthma, right? So asthma is episodic, and the hallmark of COPD is that it recurs. Periodic exacerbation. So if you get the history, and someone comes in and says they're short of breath, ask them about it. How long has this been going on? When you notice it, has it been the same since it started 3 years ago, or do you feel like it gets worse and better at periods of time? I feel like it gets worse and better at periods of time, or not. So ask those questions, because what you're trying to do when you ask history questions is you're trying to refine your differential. Decide whether or not there's a high enough clinical index of suspicion based off your history and physical to send this person for a study. You don't just want to send everybody for every study, right? You have to use your history and physical to get your judgment. Well, he has the history consistent with this. Why? What do you mean? Well, he said it's been going on for about 3 years, and when he gets these episodes of shortness of breath, they last about 4 months. Good. Good job. Good job, doctor. You used your clinical skills to make a clinical judgment, right? And then later on, right, so periodic exacerbations, right, and we talked about infections. So if somebody gets sick, they have exacerbations, they get environmental triggers. Over time, later on in this disease process, just like when we talked about asthma exacerbations, right? They get worse for a little while the body's still trying to mount a response, and then things start to slow down at the end. So later on in the disease, people stop coughing as much, and dyspnea becomes more predominant symptoms. But early on, that's what they're going to be complaining of. And like we said, there's an overlap between these two conditions, and chronic bronchitis patients over time, if they continue smoking, eventually develop, so it works its way from the airway down into the parenchyma of the lungs. All right, so these are the two types of COPDers, and I've got a great picture coming up. This picture is a blue box. I love it because it has some nice facts about these and how to differentiate them. Plus there's pictures, and I love pictures. Because when I close my eyes and I'm taking a test, I can remember the picture. All right, so blue bloaters. This is a term that I learned. I'm not sure we really use it anymore, but it helps to, still in the literature. But chronic bronchitis, so chronic inflammation of the bronchi and airway. So we call them blue bloaters because they're always a little hypoxic. They're airflow, they're obstructing airflow, so their SpO2 is usually a little bit low. The CO2 is usually a little bit higher than normal. But they're usually not they're usually not out of range in terms of their pH, right? Because if this is a chronic condition, even though they're retaining too much CO2, their kidneys will come in and usually compensate for that. Chronic heavy cough, heavy sputum, again, there's our little definition again. So this is the presentation. They might be a little cyanotic. Remember what we said, those sounds? Okay, so we're not talking about stuff in the upper airway. We're down in the bronchi and bronchioles. So the wheezes in the bronchis. That is true clinically, but it's also a nice clue when we're taking exams. So if you're down to the last two, and one of them's pneumonia and one of them's COPD, and they say wheezing or bronchi, then that's your extra clue that it's in the airway versus crackles, which would be down below. So just little clues when you're taking tests. So edema, that was one of our first lectures where we talked about extrapulmonary signs of pulmonary disease. So that edema. So sometimes, again, the heart's connected to the lungs, knee bone's connected to the thigh bone. So when there's any sort of heart disease, sometimes that can back up into the lungs. And then if there's problems with circulation in the lungs, which is what we're describing here, then that can cause changes in the periphery as far as backing up in the right heart. So we talk a lot about left heart failure in cardiology. We'll talk a little bit about right heart failure in pulmonology and how that works. And then of course infections, we've already touched on that. They're very, very common. In fact, when we talk about routine treatment of exacerbations, we usually give antibiotics, which is not the case for asthma. Typically these patients are overweight. So this is emphysema. These are our pink puffers. So these are folks that have maybe a normal airway, a normal conduction, but their lungs, the tissue has become destroyed. And so something happens to the physics. Because remember, we draw air in by creating pressure differences. And so if you have a bunch of hollowed out tissue in there, then you're not able to suck that air in as easily. But more importantly, it's harder for you to push that air out. So they're constantly working to breathe to help push that air in and out. It's not relaxed, it's not casual, it doesn't happen passively. Sometimes you'll see them purse their lips. They're trying to create a pressure difference in order to try to get that air out. So they get thin because their metabolism's so high because they're working to breathe a lot. They look like they're having trouble breathing. And it really just has to do initially with the physics, because again, the lung tissue is damaged. They change that pressure difference because of lack of tissue, and so they're having to actually help pull that air in and push that out using the musculature, the diaphragm, the intercostal muscles, and then changing the physics of the airway itself by pursing their lips so that they can push air out. So cough is not going to be the predominant. So in chronic bronchitis, you have that mucus, it's nasty, it's in that airway, they're coughing. It's less predominant, so less cough. They're going to be very, very short of breath. When you listen to them, you're not going to hear the bronchi or the wheezing. You might hear a little bit of wheezing, but you're not really moving air. So overall, you don't hear as many breath sounds. Again, patient weight loss, because they're burning calories trying to breathe. They get a little pinker from that respiratory effort. Over time, that changes in their breathing, causes their chest to become, so that AP diameter, I know you guys remember that from Clin Skills. This is where that AP, why do we do that, right? This is where, if you do a ClinCore on COPD, then the AP diameter will be increased in patients with emphysema. And that is a mechanical change over time. And then posturing, right? Again, just like the pursed lips, People are trying to posture, lean forward. They're trying to help the physics of the air movement because it's usually a passive thing. It's not active. So they're having to activate certain things in their body, including positioning and using accessory muscles to move that air in and out. All right, so this is a picture. It pretty much covers everything we already talked about. I won't go into any more detail on it, but I like it as a review. And like I said, I do have it, when we do the review for this particular test, I'll reiterate it if we need to, but it's probably at least one blue box on my test. This is something to be familiar with. All right, so chest x-ray, so remember we're probably going to do this. This is where pulmonology as opposed to endocrinology we don't have to deal with a lot of labs. Usually 90% of what we deal with is imaging studies, which is nice. We don't have to get into the details of those as much, but if we do get a chest x-ray, it doesn't necessarily diagnose COPD, but we can establish a baseline, which is important, and then we can help rule out other diagnoses. So sometimes patients present with cough, shortness of breath, long-term smoking history. They may have COPD, but they also may have lung cancer, right? So we at least at some point want to get a chest x-ray on these patients. When we talk about COPD exacerbations, certainly that's going to be part of the workup. Chronic bronchitis for the chest x-ray, it's going to be non-specific, really. Maybe a little bit later, we talked about how same way systemic hypertension can cause changes to the left heart and lead to heart failure. The pressure coming back from the lungs, we call that pulmonary hypertension, and that can cause right-sided heart changes. Irregardless of which side of the heart it's on, this can lead to heart enlargement, right? Heart's a muscle, so if it has to work harder, then the muscle will eventually build and become hypertrophic. And then emphysema. So as we discussed, that big barrel chested, so the chest cavity, when they take an inhalation, will look hyperinflated. Lots of air trapping in there. The diaphragm will look flattened, won't be nice and domed. All that work of breathing will get that increased chest to thoracic size, so the cardiac silhouette will look smaller. I think we got a couple pictures of that. So again, this is the emphysema. This is normal. So we've got that big hyperinflated chest, and the cardiac silhouette looks measly and small in there. So lots of air trapping in there. Diaphragm is not nice and domed. ABGs, again, we would probably not be getting these on a routine basis. We would probably be getting them if the patient came in an exacerbation. For chronic bronchitis, right, we've got that CO2 trapping. We're not able to ventilate that CO2 effectively to move that air exchange. So we've got increased CO2. But typically, because it says chronic, right? Typically, the kidneys have upregulated retention of the bicarb, and you will see a normal pH. But you will also see that CO2 is going to be higher. And will the bicarb, if it's compensated, will the bicarb be elevated or decreased? Elevated, yep. So CO2 will go up, bicarb will go up as well. So the pH may be normal, but all of the values will not be normal. All right, so sputum cultures, those are very important, especially when you have a patient coming in for an exacerbation, especially if they're frequent and you use antibiotics a lot, because we have something called resistance. And so if someone's having an acute COPD exacerbation and you give them antibiotics and they don't get better, then it is very, very helpful to have a culture brewing, and potentially not the greatest, it's not like a biopsy, right? It's not like a blood test. But if you can try to get that sputum, then ideally, at the same time you realize that the antibiotic you gave the patient isn't working, you can have those results back and hopefully identify what medication adjustment you need to make. EKGs, and it's not part of the evaluation. We're not looking for anything. This isn't, you know, acute coronary syndrome or anything like that. But if you do get it, these are some of the things that you can expect to find. Getting one as a baseline, because usually patients that smoke a long time, that are overweight, that are unhealthy, a lot of them will also have cardiac problems. So these are these geriatric, complicated internal medicine type patients that you'll have the luxury of taking care of at some point. So we'll talk about chronic pulmonary hypertension and pulmonale later in the lecture, or later in block 2. I don't expect you to know this down here, so let's not spend any time on that. Bronchitis versus emphysema, this is a little chart. Really what I'm trying to get you to highlight here is what I highlighted. Bronchitis, this is the patient will describe, heavy cough, copious sputum, and then, sorry, and then over here, yeah. And then over here, predominantly these patients are going to be very dyspneic. They're going to be very short of breath. They're not going to come in and be like, you know, the real heavy, nasty, you know, coughing into stuff. They'll be more the kind of quiet, faint heart sounds, faint because of the barrel chest, faint lung sounds because they're not moving air very well, and they'll be very short of breath. So that's the big point here. A couple other things you can look at. Those are the big clues. So PFTs, as you can expect, right? We're going to have some obstructive airway. With the chronic bronchitis, right? We're going to have that scooped out. So the volume will be sustained. The FVC will be close to normal, or at least within the lower limit of normal. But this flow will be scooped out, as we say, so the flow will be slower. You won't get that air moved as quickly. Now, as we transition into the emphysema later, then we have that decreased FVC. So the volume goes down, but our total lung capacity goes up, which would make sense because what did we say went up? If the FVC is down, residual volume, good. All right. So this is this is going to be on your chart. I don't know if you remember that chart I gave you during PFTs, but I'm going to give you that chart again. This gold staging, clinically, we stage things because it's easy to use them for communication. They give an idea of the severity of someone's COPD. So if you say they're gold 2, then we assume that they're moderate severity. We say gold 4, then we're talking about a very different patient. This will be on the chart, so you want to memorize it. You'll have the PFTs, you'll be able to say which gold it is, and you'll understand that we use it to stage things. What I want to make sure you're not confused about is that this does not translate directly into which meds we use. So I just want to make that clarification. When we talk about gold, it is more a definition type thing, a communication type thing. When we talk about management, we'll talk about what we actually use for that. There is some correlation, there is some overlap. That's why I'm going to give you all of this information, but the gold is tied to that forced expiratory volume. Specifically. All right, here's that chart again. There's an example PFT. So I'll ask you just simple questions. Start with the FVC. Is the FVC decreased or normal? Normal. Is the FEV1 FVC ratio decreased or normal? Decreased. So we have obstructive. And we knew that because we got post-bronchodilator data. Is it reversible? No. So it's not asthma for the test. Still could be asthma in real life, but for the test it's not asthma. So this is obstructive airway disease, non-reversible, right? Irreversible obstruction, which is probably COPD or other, right? But probably COPD, and then we come over here and we can stage it. And the question I asked is, so which stage would it be?
Gold 3.
Say it again? Gold. So FEV1. Gold 2, yeah. FEV1. Just remember, we're looking at the post bronchodilator, FEV1. We gotta come all the way out here. No, wait, in line. Hold on a second, yep, 57. So 57%, we come down here, that fits into the gold 2. And that's how you gold stage. And again, I will give you this chart, so don't start trying to put numbers in your head. Oh yeah, and then the second question is this, so this patient, we said COPD, would you push this patient more towards the chronic bronchitis category or the emphysema category? Nope. Emphysema is the increased residual volume. If we come back to emphysema is more the decreased FVC. So emphysema is when we lose actual tissue in the lungs themselves and we trap air. So the air that we're actually able to move, I know this chart's a little bit of a misnomer, but you know, I should have used the same chart, but this FVC is decreased. So it should be way up here. So if we overlaid that in here, then the FVC is decreased. So for this example that we used, the FVC was normal. It wasn't great, but it was normal. So we wouldn't necessarily push this into the emphysema. All right, management. So inhaled bronchodilators. So this is going to be part of the treatment. We use this in asthma. We'll use it in COPD. It's helpful. All these medications that we are going to talk about for COPD, unfortunately, none of them really stop the decline in lung function. They usually help with symptoms only. There's one thing, well, there's two things. So 2 interventions that we can make that actually can change the outcomes of COPD. One of them we already talked about. Stop smoking. And the only other one that affects mortality in terms of whether or not these patients die from COPD or not is oxygen. So just keep in mind, especially when you have patients, you can play around with the meds, you can help them feel better, but if they continue to smoke, there's really nothing that you can do outside of eventually giving these patients oxygen that's going to affect their outcomes. And even then, oxygen only affects mortality. It doesn't affect morbidity. Go ahead.
If you had a patient that quit smoking, would they ever be a candidate for lung transplant, or would they not be because of the previous history?
I have no idea.
Okay.
Yeah, so the question was about lung transplant and history of smoking, and I'm not really sure. I guess it just would depend on a ton of other things. I'm sure active smoking, there's a lot of things that you have to figure it out, but I'm not really sure they would do it. I'm sure it'd be some, if they had money, they would do it. All right. So then we have SABAs, LABAs. So our SABAs, those are our short-acting beta agonists. We already talked about those in asthma. Those are the quick ones. We talked about LABAs, but in asthma we only talked about it when we combined it with a steroid, our Symbicort. This time we can use them by themselves. We've got drying agents. Those are our LAMAs, our tiotropiums, our ipratropiums. So we've got things that bronchodilate, We've got things that decrease the mucus. These ones are a little bit more common in COPD. Why? Because we're dealing with a lot more mucus. Mucus is predominantly what's causing their symptoms, the overproduction of mucus, the coughing. And then of course the airway remodeling that's a result of smoking as well, that's where we use those beta agonists. Corticosteroids, those come in a little bit later. In asthma, we love them right out of the gate. In COPD, it's a different population, it's a different pathophysiology. They can be used, but we don't bring them in as early as we bring them in with asthma. The big things that we're hitting in COPD are open up that airway as best we can and get that mucus out of there as best we can. That's what's going to help the patient reduce the symptoms. And then we talked about oral steroids. When we talk about exacerbations, we'll touch on that. And then antibiotics. Those are going to be something that we are going to use. All right, this is FYI. This is the old COPD guidelines. So we talked about asthma and how there's all these different organizations that make their own recommendations on what medications we should be using to manage asthma. COPD, we typically just use one organization. They have recently updated their guidelines, not recently, but 2023-ish. I'm going to show you the difference between the guidelines, and I'll let you guys make the inference. So this is what we used to do. Patients would come in, you'd have your medic or your nurse ask them all these questions. They would rate all of their symptoms. How short of breath are you? You know, talking about how often you have a cough. So we would get the symptoms, and then we would put them into a little calculator, so to speak, and determine what category they were in. How often have you had exacerbations? How often do you have symptoms, right? So we're determining, kind of like we did with asthma, we've got A, B, C, and D. That's kind of like our intermittent, persistent. So again, we're just using our history and physical to help put someone into a treatment category. And then of course that correlates to, these are the current recommendations for what we should be prescribing. So these are the updated guidelines. And the only difference that we have made between these guidelines, where we had A, B, C, and D, and these guidelines, where now we just have A, B, and E, is we have taken group C and D and we've just made them one group, which I like. Make it easier, right? So if patients have had 2 or more exacerbations in the last 12 months, or any hospitalization for COPD, and then really any symptoms of shortness of breath, they're in E. So what they'll come in is they'll say, I can't breathe. They'll come in and they'll be yelling at you, and I can't breathe, and they'll be very frustrated. They'll be so upset that they'll have to go out and have a cigarette, right? Lots of coughing, lots of sputum. Winter months, right? The patients will come in because they got sick, just like in asthma, right? So they got a little sick, that exacerbated that already present airway obstruction, caused a little bit more inflammation on top of it, caused a little bit more obstruction, caused a little bit more mucus production because now they're fighting off a virus on top of this. And now their symptoms are significantly worse. So this is kind of where we go when we talk about treating them. If the patient is not already on some sort of short-acting, just put them on it. Give them an albuterol, give them an ipratropium, the SAMA or the SABA, give them a short-acting to use for their symptoms. Antibiotics, we won't go into detail about which antibiotics here. But you're going to consider antibiotics. Do I need to treat this person? I would get a chest x-ray on them. I would see if there was a low-bar pneumonia. We'll talk about pneumonia later. And then there are really just regular antibiotics that we're going to consider. And they cover most of our normal, typical community-acquired pneumonia. We'll talk about that in a separate lecture. And then steroids. So steroids we talked about with asthma exacerbations, just little bursts, just a couple days, maybe just one time in the clinic before you send them off. Here we're going to give them a little bit of a long taper. This is a chronic condition. We don't expect them to bounce back like an asthmatic would. So we keep them on a little bit longer. Plus this is usually a different population, older population. Give them a little bit more of a slow crawl out of these. Getting them to stop coughing. A lot of people will throw on some Tessalon pearls. Well, this is what they're going to be pissed off about, and this is what they're going to want you to treat, is that cough. But don't feel obligated to do that. You know, let them know we want you to cough that stuff up. If it sits down there, it's going to be full of bacteria. It's more likely you need pneumonia. Tell them to get some over-the-counter stuff if they want to take it, but I typically won't prescribe that, and certainly you don't want to give people sedatives. They're tired, it's keeping me up all night, I can't sleep, I need my Ambien. You know, tell them to take some melatonin. So we talked about, you know, which antibiotics we would pick. So these are the typical ones. When we get into, we're talking about pneumonias later on. We're going to talk about strep pneumo in the first block of the first lecture of the next block. If I want you guys to memorize any of these right now, or for November 14th, I will let you know at a later time. I'll be specific about it. Just understanding that when you decide to put someone in antibiotics, there's two different kinds of patients we need to consider. Right? And I hope it makes sense to you that if a patient is treated more frequently for this, if they've had more than 4 exacerbations and they've been treated, it probably means that we need to be covering for more types of bacteria. So it's not a perfect science in medicine, right? You know, when we make these decisions, you're like, well, this is just how we categorize things so we can get to an answer. And then we try them, then we have a follow-up and make sure that what we picked is working. But we need to start somewhere. I won't spend too much time on that one. Alpha-1 antitrypsin. It's kind of like that cystic fibrosis. We will see patients presenting earlier with respiratory symptoms. They'll sound like COPD. You'll do some studies, you'll get a chest x-ray, you know, you'll tell them, you know, you're just out of shape, whatever. But something's just not fitting. This person's too young. But if I put this person's complaints into ChatGPT, right, and I forget to put their age in there, and I forget to put that they didn't smoke, it's telling me that this is consistent with COPD. So keep this kind of stuff in the back of your head for, you know, 4 months later when you're like, that guy's back again? Or that guy still hasn't passed our PT test? And consider these things. You've got a young 20 to 30-year-old, he's never smoked. It just doesn't make sense. I see that guy out there working out all the time, but yet he still can't pass his PT test. Something's off. So keep these things in mind. Refer. Don't, you know, order genetic tests right out of the gate for someone that's short of breath, but keep these things in the back of your mind. Keep them in your differential. Again, young guy, non-smoker. This has to do with this alpha-1 antitrypsin. It's usually found in the lung. It inhibits the function of inflammatory cells. So if you're deficient in it, you've got airway inflammation that mimics COPD. So earlier onset, we talked about this chest CT findings, but if you're thinking it, in most cases, you're going to be referring. So genetic testing to diagnose it, you'll see significant lung damage because that alpha-1 antitrypsin is deficient, and so you have airway inflammation throughout, including in the lungs. If these patients smoke, they get significantly worse at a faster rate. Have you seen it? I'm sure people continue to smoke. Smoking is very addictive. but we can replace it. So not much more I want you to know about that other than it exists. And you might get a question about a patient who has symptoms consistent with COPD, but they're only 20, right? And their dad had the same problems when he was in his 20s, something like that. I want you to know that word, I want you to know it exists, and I want you to know that it's in the differential for shortness of breath and respiratory symptoms. Additional considerations. So again, other differentials, we already talked about the alpha-1 antitrypsin, cystic fibrosis, we mentioned asthma. Just keeping in mind that if it's asthma, and they've read the book, that FEV1, post-bronchodilator FEV1 will increase more than 12%. So these are all things you need to consider in the differential. If you're thinking COPD, convince yourself it's not one of these. Well, not out of the gate, but if they're 50 years old and they're having these symptoms, probably throw that one out. If they're 50 years old, you can probably throw that one out too. So after a certain age, but if they're young, then you need to consider them. Why we care, right? So we talked about asthma, why we care, why we want to keep it under control. It's because it can cause long-term changes in the lungs. With COPD, long-term pulmonary hypertension can lead to the same changes in the left heart that uncontrolled high blood pressure can lead to in the right heart. So it can cause the same types of symptoms, lower extremity edema, poor ejection fraction, but we see it on the right side of the heart instead. And this word choropulmonale, we'll talk about that. That is literally just a Latin word that describes the right side heart changes that are associated with pulmonary hypertension. And then pneumonias, frequent pneumonias. I just looked up one of my favorite actresses just died, and she died of pneumonia. So she was older, but I looked up, and every time I see that, I'm like, how did you die from pneumonia in 2025? But it happens. We'll talk about that a little bit. Stop smoking, and don't forget, infections are a lot of the morbidity associated with this, so we want to make sure that we're vaccinating. All right. When do we need to consider referring? So if they're too young, if they're in that group E, meaning they've had more than 2 exacerbations in the last year, or they've had a bunch of hospitalizations, they're taking all these drugs, you want to consider referring them. Otherwise, you can manage them usually. If it's getting really bad really fast, right? So they just keep coming in, and it's like, man, you're not even getting a break in between it. You repeat a PFT, and they've gone from a gold 1 to a gold 4 in 6 months. Now you don't necessarily, when I say refer, I'm talking about like internal med potentially, right? So if you're thinking about maybe this patient needs oxygen because they can't keep their sats up, refer, and then obviously when to admit. You have a patient come into your clinic, you think he's having a COP exacerbation, you give him O2, you're still below 90. You can't get his sats up. Obviously, if they're unstable, remember we talked about mental status being a sign of instability. Bad home care, or if you're like, this guy's a mess, he's had 2 heart attacks in the last 3 years, he's got COPD, he's still smoking, I do not want him to die in my clinic, then you need to think about transferring them as well. We talked about, somebody brought up lung transplant. So that is an option, and I'll ask about what qualifies someone for it. I think that's interesting. Not a great survival rate, but it's better than nothing. And then when we talk about emphysema, we talk about all the air rate trapping. I don't expect you to know this. This is FYI, so I'm not going to waste time on it.